So in part 1, we've covered the basics of what a DAT is, what must be done if it's positive, and now we're going to apply those results to different situations. And students have a really tough time with this. That's why there's a chart in the course where you fill it in and study that for the exam, and you'll have all the questions. So without further ado, let's start part 2. There's different ways to classify hemolytic anemias, and this is the one we're going to use. There's the autoimmune. In the autoimmune, there are 4 types that you must memorize. There's the warm autoimmune hemolytic anemias, which I'm just going to call warm autos. Cold agglutinin syndrome, which I'm just going to call cold autos. Mixed type is both warm and cold. And paroxysmal cold hemoglobinuria, which is a special type of hemolytic anemia. Then there are the alloimmune anemias, and this is due to either a hemolytic transfusion reaction, either acute or delayed, or hemolytic disease of the fetus and newborn. And then last but not least is drug-induced. There's drug-dependent and drug-independent. We'll talk about both types. So again, this is a list of the classification that you need to memorize. Warm autoimmune hemolytic anemias are the most common type of autoimmune hemolytic anemias and the most difficult problem encountered in the transfusion service. The DAT results in 67% of the cases. The red cells are coated with both IgG and complement. 20% IgG alone, 13% of the case complement alone. So what I want you to remember is the warm autos are the most common, and in most cases the cells are coated with both IgG and complement. When you're working up a warm auto, the serum plasma may have little free autoantibody, because if this is the start of the disease, as the antibody is being produced, it's going to go onto the red cells. So all the antigen sites on the red cell will be coated, and once that saturation occurs, then you will have the detectable autoantibody in the serum. Approximately 50% of warm autos will have an autoantibody reactive with all cells tested. The problem or the danger is that in addition to this warm auto, there may be an alloantibody present. So you prepare your alluate, and the alluate is usually reactive with all cells tested. So it mirrors what it did in vitro with the DAT testing, with your screens and your panel, and then when you remove that antibody off the cells, we get the same type of reactivity. Negative reactions due to complement only or presence of drug-induced antibody are possibilities. And the one time it really makes me mad to this day, it takes a long time to work these up. It takes hours and hours. And so I had gotten to the point where I had prepared the eluate, but my shift was over. So I had my colleague go ahead and test the eluate. Well, guess what? There was an anti-JKA alloantibody underneath the warm autos. And what you need to remember about anti-JKAs is they are notorious for causing acute hemolysis when the donor cells possess that antigen. So this could have been a really, really difficult case in that if we hadn't detected the JKA antibody and provided JKA negative blood, we could have potentially killed the patient. Warm autoantibodies can be very challenging and very complex. Autoantibodies often initially directed against the Rh antigen complex, as we spoke about before, anti-e, but the patient's e positive. The specificity against simple Rh or other blood group antigens occasionally are seen. If simple specificity gives antigen negative blood, if it's a high frequency or complex antibody, antigen negative blood may not be practical. You may not find antigen negative blood. Over time, these warm autos will lose their specificity and will be reactive with all cells tested, including the patient's. And I want to interject that I've worked up hundreds, if not thousands, of warm autos, and it gets to the point that you know exactly what you need to do. You do the antibody identification, then your autocontrol is positive, you do the DAT is positive, you do the LAOET, it's reactive with all cells tested, and once that workup is done, then you do your best to find blood for that patient, and it's all going to be incompatible. Autoabsorptions are done to determine if there's allo along with the autoantibody present. And I want you to memorize the procedure. This can only be done on patients who are not recently transfused. Because if they have been recently transfused, what we're going to do is remove antibody from patient cells, then incubate the patient's serum with those cells to remove any antibodies, specifically autoantibodies, so maybe we can get what appears to be a compatible cross-match. So, in blood banking, adsorption refers to adherence of an antibody or antigen onto the surface of the red cell. Autoabsorption is used to remove autoantibodies so that underlying masked alloantibodies may be identified. If the red cells are heavily coated, you may need to pre-treat the patient's red cells with a product called ZZAP. And ZZAP will remove immunoglobulins from the cells. It's a combination of proteolytic enzymes, papain, and dithiathreatyl, DTT. It removes immunoglobulin and complement from the DAT positive red cells. So we want the red cells naked. We want them just not to have anything coating their cells. And ZZAP is a very popular product used for this purpose. But you need to keep in mind that ZZAP will destroy CAL, MN, and DUPI antigens. So if you do have an alloantibody underlying, and it does have one of these specificities, then you're going to miss it. So be aware of the limitations of your reagents that you use in the blood bank. And so again, the danger of using ZZAP, if you have one of these antibody specificities present, you will get a false negative. After the RBCs have been treated, we're on to the final step, which is incubation of the patient's serum or plasma with the patient's treated red cells. Now remember, this is an autoantibody. It's directed against antigens on the patient's red cells. So you add the two together, you incubate at 37 for 60 minutes, and I like to agitate about every 15 minutes or so to make sure that as the cells, because the cells will settle, so we want to reconstitute it. The autoantibody will attach to the treated red cells and then be removed from the serum or plasma. So you say, well, gosh, we just removed the antibodies from the cells. Now we want to put it back on? Yes. What we want to do is reduce the concentration of autoantibody in the patient's serum by adding and incubating them with these treated cells, which are naked. And now they have room for more autoantibody on them. So once the incubation is up, we want to separate or harvest this adsorbed serum or plasma by centrifugation. And I always put ×1, because sometimes this is not enough and you're going to have to pre-treat another aliquot and do an autoabsorption ×2 and maybe even ×3. 3 is the maximum, because then you may be diluting out the antibody instead of removing it. So again, add patient serum to these treated naked cells, incubate so the autoantibody will be absorbed out, harvest the serum or plasma, and test it against your screen cells. Now, if it's negative, that means there's autoantibody only. So you run the screens, it's negative. Yay! You have successfully removed the autoantibody because it's negative, and there's no underlying alloantibody because it's negative. If you get negative and positive reactions, alloantibody may be present, so perform a panel on the adsorbed serum and identify the antibody that's present. If after doing this adsorption all the screen cells are positive, the procedure was unsuccessful, and you want to repeat the entire process with that same aliquot, the ×1 aliquot, again, add it to another aliquot of treated cells. So here's an illustration. I love illustrations. So you can see that alloantibody is green and the autoantibody is black. So what has been done is in the second tube, the cells are treated and they become naked because the antibody is knocked off. So you take those cells with a fresh aliquot of patient serum and then you incubate. So following successful absorption, only the alloantibodies will remain in the serum because the autoantibody has an affinity for the patient's red cells. It's an autoantibody. So in that final tube, you see all that's left. This patient had not only an autoantibody, but they had an alloantibody. So I really want you to spend some time. Your textbook does a really good job of explaining this as well. War mottos, transfusion considerations. It is best to avoid transfusion if at all possible. So if the patient has an 8-gram, 7-gram hemoglobin, put them on heavy-duty steroids to suppress the immune reaction, iron supplements, and try and build them up that way. But if that is not the case, a lot of them will come in with 4 or 5-gram hemoglobins. If transfusion is essential, give the smallest volume of red cells necessary to maintain oxygen transport. In our first case, the patient I was talking about that had 1,000+ positive DAT, our pathologist had to split the unit, and he sat with the patient during that first transfusion of red cells, which I think it took between 2 and 4 hours. They wanted to give it very slowly. But that's how concerned he was that this autoantibody would just massively destroy these transfused cells. More like an acute hemolytic transfusion reaction. If alloantibody plus autoantibody is present in the blood must be negative for the antigen to which the alloantibody is directed. Serologically compatible blood may not be found, and it's very, very uncomfortable to transfuse incompatible blood. Some facilities perform the following. Be aware that this may lead to a false sense of security. You must prove the presence or absence of alloantibodies first. Cross-match with adsorbed serum if that was successful. Perform an electronic cross-match, which in this case I'm not comfortable with, because if you do have incompatible donors or positive screens, the patient's not eligible for an electronic cross-match. Or finally, this is what we always did, was cross-match with serum or plasma and then select those units which react the weakest. I apologize for the background on this. I borrowed this slide from one of my colleagues and I just couldn't remove this formatting. So, the autoantibody may still be present because you were not able to absorb it out. And even then, that's just an aesthetically pleasing cross-match. So what we do, I usually set up 4 to 6 units and perform the cross-match and look at the strength of the reactions. Then, the donors I will use for transfusion, I will select those that have the weakest reaction with the patient's serum. So if you look at these 3 donors, we have a weak, which is usually microscopic, a 2+, and a weak. So I'm going to pick the weakest reactions. So let's say I had a 4+, a 3+, and a 3+. I would choose my 3+. And again, the term used for this type of cross-match when we select incompatible blood, we call it least incompatible. And that's just to make us feel better, because blood bankers do not want to transfuse incompatible blood. But again, ultimately, this is incompatible blood that you're transfusing, and nursing service better be on top of this patient at all times during the transfusion. So now we transfuse the patient. Patients with no apparent hemolysis do quite well. The difficulty is with pre-transfusion testing, that you get these positives and you get the positive DAT and you have to do all this additional testing. The survival of transfused red cells in these types of patients where there is not apparent hemolysis, those cells will survive about the same as the patient's own red cells. So, we feel pretty good about these patients. Patients with active hemolysis are very challenging. The transfused red cells may be destroyed more rapidly than the patient's own cells. This may increase the hemoglobinemia and hemoglobinuria, and it may cause disseminated intravascular coagulation. Transfusion is a clinical decision and should not be withheld due to serological incompatibility. So if you have a patient with a 3 or 4 gram hemoglobin, the physician really has no option rather than to transfuse this patient. Cold agglutinin syndrome, CAS, this is less common, but it's the most common type associated with cold reactive autoantibodies. It accounts for approximately 16% of immune hemolysis, and it can occur as either an acute or chronic form. The acute form is secondary to lymphoproliferative diseases or Mycoplasma pneumoniae infections. I want you to remember that. We talked about this before in serology. The chronic is seen in elderly and may result in Raynaud's phenomena and hemoglobinuria if exposed to the extreme cold. And if you remember Raynaud's phenomena, that's where the peripheral circulation, either the hands or the feet, they turn blue and colorless, like there's no blood in that area. It's often characterized by room temperature agglutination of EDTA cells to the extent the sample appears clotted. You've done hematology. You've learned about cold agglutinins and how they can really cause erroneous results in your analyzer. So you need to be able to identify them, and maybe the blood bank can help you. Or if you see them, say, hey, this patient has a real strong cold agglutinin, just want to give you a heads up in case you get an order on this sample for a cross-match or a type and screen. Do not compartmentalize yourself. In cold agglutinin syndrome, the DAT only complement is detected on the red cells. And this is pretty cool. The reason that complement is the only protein present. So here we go. So the antibody class of these cold agglutinins is IgM, which in vivo binds to the red cells in the peripheral circulation where the temperature falls to 32 degrees centigrade or less. IgM causes binding of complement in the cold. When the red cells return to the warmer circulation of the body, the IgM dissociates, leaves, and then what remains is only complement. Because complement is the only protein coating the cells, the eluate will be negative, as only complement is binding to the red cells. So I want you to study this a couple of times because it's really cool and it allows you to make sense as to why complement is the only protein coating the cell. So moving on to testing the serum or plasma, the IgM reactive antibody associated with immune hemolysis, not just that a cold agglutinin is present, but is causing hemolysis, reacts at greater than 30 degrees centigrade, and 60% have titers of 1,000 or higher when tested at 4 degrees centigrade. We had a patient that, when you're doing a cold agglutinin titer, you have tubes 1 through 12. 12 is your auto control. She was positive up to tube 11. So we learned when she came in, we went out to 24 because she was that high of a titer. And I can't remember the number. I don't know if it's 10,000 or 20,000. But the good news for me as an instructor, I froze her serum or plasma, and we used it in the MLT program when it came time for cold agglutinins, that I diluted her out to where 1 cc of plasma diluted out was enough for the class of 12. These antibodies may show high thermal amplitude. What that means is at immediate spin they're 4 plus, and at 37 they're 4 plus, not because it's IgG, but because the cells were agglutinated. They never, the cold agglutinin never came off the cell. And then at Coombs, you can tell when you're washing them. I'm sorry, I laugh because it's so funny. So I'm washing my cells for the Coombs test, and when I squirt the saline in, there's this 4 plus agglutinin. And I beat the devil out of it, in between washings. I tap, 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 really trying to make the cells fall apart, but no can do. And so at Coombs, when I add my 2 drops of IgG and spin down, it's 4 plus. But it's not 4 plus because of IgG coating the cells. It's a false positive due to this antibody, this cold auto, showing high thermal amplitude. It just doesn't want to let go. Anti-big I is the specificity, and less commonly anti-little I is present, and this is associated with infectious mononucleosis. We mentioned this in the serology class. Bring it back to the front of your brain again. Antibody specificity is not diagnostic, as anti-big I is seen in healthy patients, but in healthy patients, it rarely reacts at titers above 64. And it would be interesting to draw each other and do a cold agglutinin titer on your own blood and see if you have one of these nuisance. And that's why we call them nuisance. They're not clinically significant because they're not causing hemolysis. Pre-warm testing may eliminate the reactivity, and we'll talk about that in a moment. These antibodies may cause false positives in the forward and reverse typing. In the forward, because the cells are so heavily coated, they spontaneously agglutinate. So you have agglutination with anti-A, anti-B, anti-D, so they appear to be an AB pause. What must you always do when you have an AB pause? You have to run a negative control. Your negative control is 4 plus. And so that invalidates your test. In the reverse, the cells have the I antigen, and they will agglutinate. So you have the forward typing as AB pause, the reverse typing as group O. So what are you going to do? And that happened to me, working a night shift, emergency cross match from the ER, and so what are you going to do? Well, when in doubt, you're going to give O negative to the patient and continue working on the problem. Or hopefully they can wait until your workup is complete. So again, clinically significant titer of 1,000 or greater when tested at 4 degrees centigrade, high thermal amplitude. They do not want to let go. The specificity is to the big I antigen, or in the cases of infectious mono, the little I antigen. If you have a titer 64 or less, it's a nuisance, nothing to worry about. And again, this may cause ABO discrepancies. So how do you identify this? So we identify it by doing a cold screen. So in this case, you see there's 2 screen cells, 1 and 2, the autocontrol, and 2 cords. Why did we pick 2 cord cells? When you're born little I positive, and as you grow up, you transition to your adult phenotype of big I. So cords are, if we're looking at a big I specificity, cords are negative, so our expectation is 0. And then the A1 and A2 cells are not tested. So this is an individual who has a cold autoantibody and is anti-big I. In the second case, it's not unusual for patients to have a weak anti-H. So in this case, we have a group A person, and their screens are positive. The cords are 1 plus because you are born with H antigen. It's just not as heavily coated with H antigen as when you grow up. So we have a weak reaction. And then A1 and A2 cells are present. And if you remember, they have a high amount of H antigen. So in this case, we have a patient that has both an anti-big I and a weak H. And I do want to point out in A that the cells can be weakly positive. Some babies grow up faster than others, and so they may have more I antigen. So I would also say that if you have a very weak reaction with the cord cells, that's okay. This is the end of part 2 of Unit 13.